And the last subject is diabetes. I'm going to go over very quick about just the names, mechanism of action, side effects, and what to know. And then we will go into the names, maybe how to remember. We'll see. Anyway, diabetes pre from 80 to 130, post 180. So, first line for diabetes and number two type is a biguamine, which is metformin. At least it's a one name to remember. It is a PO, and mechanism of action is increase insulin sensitivity, decrease glucose intestinal absorption, and decrease hepatic glucogenesis. So it's decreasing A1C by 1.5 to 2%. Side effects GI, as well as flatulence. It is decreasing B12 and folic acid. Adverse reaction would be lactic acidosis. So when you see lactic more than 5, anion gap more than 14, pH less than 7.35, you need to adjust dose. If you have folic acid drop, then you need to suspect megaloblastic anemia. You need to monitor for that anemia and peripheral neuropathy because of the B12. So that's one name by one mide metformin. Metformin, I think it's a macrophage. So next is going to be GLP. They all end with tide. The way how I remember is I'm gulping tide, which is silly, but that's how I remember. So GLP ended with tide. They are injections, sub-Q. They are not only decreasing A1C by 0.5 to 1.5, they also help with weight loss. They're working on this hormone GLP, and that's increasing insulin secretion, decreasing glucagon, decreasing gastric emptying and glucose production, and also decreasing appetite. Cardiovascular benefits and real protection in this group. Side effects: nausea, vomiting, diarrhea. So you need to take small pills, meals, and slowly titrate this drug. Adverse reactions would be pancreatitis, cholelithiasis. So avoid if they have history of that. Contraindicated with multiple endocrine neoplasm, MET type 2. Black box warning for medullary thyroid cancer. And also contraindicated with pregnant or lactate people. They also have a PO. PO is going to be named Rubelsis. And it has a lot of interactions, especially with levothyroxine. You have to take in the morning, about 30 minutes before meal, not with other meds, and at least 4 ounces of water. That's a PO. So if they're afraid of needles, that would be a good choice. Now, next is SGLT2I, 2 inhibitors. They end gliflozin. Gliflozin. And gliflozin, I remember with I because the SGLT2I. So that's gliflozin I at the end. Mechanism is proximal tubular, promotes renal excretion of glucose. It's decreasing A1C 0.5 to 1%, and it also is decreasing CKD progression. It is best for high risk people, established ASCVD, and also hypertension. they did found that they have cardiovascular benefits, renal protection, and also decrease heart failure hospitalization. Side effects is GU infection, UTIs, and that's because the glucose is going out. And in the urine, you also have euglycemic DKA. If you have that, hold the dose. Decrease blood pressure and increase potassium and dehydration. So you need to adjust diuretic dose. So if you are on diuretic, you need to adjust that one. Bone fractures, especially with canagliflozin. AKI, expect slight increase in creatinine when you initiate, which is normal. You also have a risk for amputation. So you need to monitor diabetic foot patients, do exams periodically. Bladder cancer, if you have a history, you need to avoid it. And some medication you have to avoid if you have GFR less than 30 or less than 45. DPP4I, the end is gliptin. The way you remember is I do drink tea, and that's Lipton, and I PP. So DPP Lipton. That's a PO, similar to GLPs. So do not take that together with GLPs. It is not for type 1 diabetes. You need to adjust those for GFR less than 30 or 45, or creatinine clearance less than 30 or 60. It is decreasing by 0.5 to 1% A1C. And the way it's working is inactivates incretins. And those incretins, they usually increase insulin and decrease glucagon. That's the action. But DPP4Is, they have increased hospitalizations. Next is going to be sulfonylureas. They start all with gl and end with ide. I don't know how to remember, but you would say gl. I'll do it. I'll be do it. I don't know. Anyway, they increase insulin release from pancreatic beta cells. So they decrease by 1 to 2%, which is good. And they are not for weight loss like previous ones. They are not for CKD or GFR less than 10. Side effects and adverse reactions are you have weight gain, hypoglycemia, that's two big ones, GI rash, hematologic side effects. Have to cautious with renal impairments, and you must take with food to decrease the hypoglycemia. So the last one is thiazole. They called TZDs, and they finished with glitazone. As you remember that SGLTs finish with glitazine as an I, and then TZDs, they are in a zone. So they are the longest one to pronounce. So for me, it's like a big zone. How they're working? They're working on PPAPY, which decreasing fatty acids and increasing insulin sensitivity. They decrease A1C by 0.5 to 1.5. Have to monitor LFTs, regular eye exam, because when it's a long zone, you cannot see anything. Anyway, how do you remember? They don't have hypoglycemic or renal adjustments. That's good. Side effects or adverse reactions is edema, weight gain, bone fractures, hepatotoxicity, So you need to monitor LFTs, bladder cancer, especially with pioglitazone, and increase CVDs, increase LDLs. So you need to avoid if you have any risk factors. You also have macular edema, which is blurred vision and vision changes. Black box for TZDs are no heart failure exacerbation. So not full heart failure. And I'm going to go over just endings. So, or the names. You have biguanine, that's metformin, GLP-1, and with Tide, SGLT2I, finish with glyphosine, DPP for I, finish with gliptin, TZDs, glitazone, sulfonylureas SU is starts with GU and end with IDE. You also have meglitinide. They are finished with glinide, especially nide, And then AGI, two names, acarbose and miglitol, and acarbose. Also for diabetes is insulin. We have long-acting, intermediate, rapid, short, and premix. And CGMs, that's the continuous glucose monitor. That's a pump. So we're going right now with hypoglycemia. And they have a rule of 15. If it's less than 70, 70, that is 15 grams of carbs, whatever is weak carbs, candy, sodas, wait 15 minutes and recheck. If less than 54, you give glucagon injection or intranasal. And with intranasal, you don't even have to inhalation. All right, how do we monitor? They have monitoring, continuous monitoring. It's called CGM. It's good for diabetes number 1, frail people, children or adolescents. It is incomparable with MRIs, CT, X-rays, not for pregnant or dialysis. For pregnant because nobody did any studies. Those monitoring, one of them is Dexcom, and it is comparable with insulin, and usually for 2 years old and up. And you have Freestyle Libre. It is not comparable, and it's for 4 years old and up. So with Dexcom, you have some Tylenol or hydroxyurea interactions. And with Freestyle Libre, you have ascorbic acid, hydroxyurea, salicylic acid, and severe dehydration. All of those things can show inaccurate results. Time range usually looking at about 70%. Insulin. So when nothing works, you add first basal insulin. You initiate at 10 units per day and increase by 2 units every 3 days. Then you add prandial insulin, 4 units per day, and increase by 1 to 2 twice weekly. So, long-acting, Levemir, Lantus, and Tresiba. Onset, 1 to 3. No peak because it's long-acting. Duration, for Levemir 12, for Lantus 24, and for Tresiba is 42. So the way how I remember is Levemir. It's Levemir, okay. So that's for me is the first one, and R goes before S, so I remember that's the first one. And the duration, I just remember all three numbers down in my head is 12, 24, 42. So it's like 1, 2, 2, 4, 4, 2. That's how I remember. Intermediate, that's usually NPH. And onset is 1.5 hours to 4 hours. Peak is 4 to 10. And duration is 4 to 16. I also remember it's kind of like only visual. I see 1, 5 over there, then 4, 4, 10, 10, 16. Almost kind of like 1, 5. But that's how I remember. Rapid acting, I have to take before food. Lispro, Aspart, and glulicine. Onset is 5-15 minutes. Peak is 1 to 3 hours. And duration is 3 to 4 hours. I just visually just memorize 15, 1 to 3, 3 to 4. You have also Aspart, another one that is called FASP. And this one is like double fast. You can even take this after food. It's working very fast, 2 to 15 minutes. The peak is 30 minutes to 1 hour, and duration is 4 hours. Next is short acting. It's a regular. This is the only one which one can go IV. Onset is 30 minutes to 1 hour. Peak is 2 to 3 hours, and duration is 3 to 6. For me, it's just memorizing the things, and in my head, I have weird things. 2 times 3 will be 6, and that's how I remember. Anyway, and premix and combo with NPHs, they work 30 minutes on set, and the peak 2 to 4 hours, and they are actually durationers from 22 to 24 hours. You have to take 30 to 45 minutes prior. You have also U500. Never heard that before, but this is more for high resistance people with daily requirements very high, more than 200 units, or patient with fluid challenges. I remember when we're switching from insulin to GLPs or SGLT2Is, you have to its requirement to reduce the dose. And I will like to go over some names again, just to kind of, I don't know how to even pronounce them, but anyway. Biguanide, that's metformin, usually first line for diabetes. GLP-1A, example. Dulaglutide, remember they end with tide, glutide. Exenatide, liraglutide. Okay, never mind. DPP for, no, let's go back to SGLT2Is, because first you give GLP or SGLT2Is. That's two main ones to give. So SGLT2Is finish with glufosine, canagliflozin, dapagliflozin. That's examples. Next is DPP4I. So as I said, they finished with gliptin, PP, alogliptin, linagliptin, sitagliptin. Next is TZDs, and that's a pioglitazone. Remember TZDs? That's also a long one that it's a zone. And rosiglitazone. They finish with glitazone. SUs, sulfurine, whatever. They start with glu and end with ide. Glimepiride, glipizide, gluburide. Okay. All right. Meglitinides, they finish with glinides. Netaglinide and ripaglinide. AGIs, just two names, acarbose and miglitol. Miglitol. All right, insulins we already know. Lifestyle changes, 4 approaches: glycemic control, blood pressure management, lipid management, and agents with cardiovascular and kidney benefits. And that is all for cardiac. For diabetes.